Tonight, we're very lucky to be collaborating with the Bath Medical Museum in bringing you this particular talk. This is our first collaboration, and we hope it'll be the first of many. I'm very interested to see how the Bath Medical Museum gets on with its mission of informing the public about the past, present, and future of medicine. And we have a representative from the BMM here this evening, so welcome. So our speaker tonight is my colleague at the University of Bath, Dr. Lukasz Piwek. He's from the School of Management. He's been here in Bath for a decade now, so he knows Bath pretty well. It's interesting for me to learn that his background is actually in behavioral sciences, and he's presumably employed by the School of Management to teach students how to predict other people's behavior. Is that right? More or less.
Amongst the other things, yes, yeah, among other things, analytics as well, lots of analytics.
Yeah. Well, there you are. You predict people's behavior in the future from what they did in the past. So here we go. Lukasz, the floor's all yours. And he's going to talk about wearable health technology.
From consumer gadgets to clinical tools with a question mark. Welcome. Good evening, everyone. Thank you for coming. Thanks very much for the invitation from both the museum and the Research Center. I'm an associate professor in data science. As Stuart said, I work at the School of Management in Bath. I have quite interdisciplinary research agenda. I come from behavioral science. I did a lot of neuroscience and psychophysics in the past. So I dip my toes quite deeply in much more computational approach to psychology, where we use mathematical algorithms, machine learning, statistical models to model human behavior, perception, other aspects. But it was a quite space where things were moving very slowly. I felt that my contribution was too incremental. I was also very fascinated with emerging digital technologies. I've always been, since my childhood, I've been into science fiction novels, Philip K. Dick, William Gibson. So I had a lot of these ideas about the future, how our reality will look like, how our life will look like, and how technology, of course, will empower us in this process. So I'm you might say, technological positivist. I'm looking at technology more as an almost extension of our evolution in some way, cognitively, intellectually, in our capabilities. It kind of resonates with one American sociologist, Marshall McLuhan, who was talking about this, that technology is a sort of extension of man. He was really very literal about this, that car is our extension of our legs, of our mobility system. It enables us to quickly move between spaces. Camera is an extension of our eye and our memory. It can capture the reality, the world around us in a way that I possibly can't, and it can record as well, so extend the memory of the images. So he had this perspective on technology as being really kind of symbiotic component of human quality and evolution of sort of intellectual capability as a result of it. I like this idea. I like this idea that, we will be augmenting ourselves with technology. And that's why inevitably I ended up over a decade ago looking at the emerging phenomenon of wearable health technology, specifically the consumer one, the consumer devices that began to be released and had a lot of sensors in them and a lot of potential. Can I ask you a question? How many of you wear one of those, a smartwatch or wearable device, a wearable ring? So like practically 50% of the group, which actually goes along with how we would look at the market in this sense. So, wait, sorry, it's shipping. So we now at the stage where wearables became pretty much an adopted technology globally. It's a huge market worth between 85 to 95 billion in 2024, and it's growing between 12 and 15% annually. there were 560 million wearables shipped globally 2 years ago, 2024, or in the 2024, and 400 million of those were somehow associated with health or wellness. And when we look at the usage, except starting, let's say, with UK, and UK adults, so how many UK adults own at least one wearable device? That's, as we've seen, around 50%, 52% specifically. And that's been rising quite rapidly. Just in January 2024, now this data is from December 2025, so 2 years before, only 35% of the population owned at least one, adults own at least one device. Now it's higher. There are 3 market leaders in the UK who own over 80% of wearable market, Apple, Fitbit, and Samsung. And there is also a little bit of age divide when it comes to the use of wearables. Not so much in age groups between 18 and 54. There is roughly similar distributions there. It goes between 40 and 50%. With the exception of this group, you can see I have quite wide scope there between 47% and 74% for an age group 25 to 34. That's simply because there are conflicting market research results from about 5 or 6 different providers, and it's really unclear exactly how that is. But what's important about this particular statistic is a very small number of users in a age group of 55 plus, 19%. Of course, kind of a slightly worrying trend, as health wearables could be specifically helpful for more elderly populations. So my research in this space started over 10 years ago, and at that time I was actually at UWE in Bristol. I moved from Glasgow University, and we had a really nice budget at that time for research, so we went for a shopping spree. I bought all the possible wearables that were on the market, including some sort of site-related technologies like genetic tests, like different smartphone apps that we could install that turned smartphone into kind of fitness device or somehow health-oriented device. And we started testing them. At this point, testing them mainly in the context of increasing levels of physical activity, a simple premise, right? We're also, of course, as I said, looking at a lot of social media services and digital networks that were also generating health data, some associated with wearable tech, some not, but all kind of oscillating around sort of digital health space. And at that time, we published a kind of mini review, you might say, in PLOS Medicine on promises and barriers of wearable technology. We thought that, okay, we are quite in the early stage of the adoption. That was, remember, 2014, 15 when we were doing this. But we thought that one big promise there was definitely predictive preventive diagnostics, right? With the idea that you have a device on the wrist or on finger or stitched into your clothing that continuously tracks some metrics from your body, whether it's level of activity, heart rate, galvanic skin response. And through smart algorithms, we turn this into personalized insights that can in turn give us some feedback about, well, the quality and status of our health, whether something is happening, right? So that was the sort of first concept of the predictive preventive diagnostics, that with these technologies, we could start tapping into, right, our future, seeing based on our past data trends, what could be some probabilities for how our future health will look like. And alongside of this, we are also looking at this other aspects of facilitating behavior change. That was, again, based on this really simple premise with wearable technologies that the device provides continuous, intelligent, or kind of cognified, maybe feedback with a detail, which is very, and then the feedback is instant, personalized, objective. So there is this sort of loop where you can look at any point and you have some insight into something that's happening in your body. And then you might act somehow on this. For example, control how much you are running, sort of, and track it, or set up goals for yourselves around other aspects. However, very quickly, we got to this point with those many, many different devices that we bought, and I was breaking them down, plugging it in, trying to crack the algorithms of how they were detecting our steps or our heart rate. But it was clear that it's not a simple task, and my colleague really put it very nicely those years ago, that you can't just give a person a weight scale and expect that they will lose their weight, right? Weight scales were around for very, very long time in our technological history. And sure, they give us this feedback and allow us to track the weight, but there won't be a sufficient component to lose weight. There is more to behavior change and more to interventions in healthcare that are required in those contexts, and especially when you have something on your body which is personalized, which is tracking your very private data, and of course taps into the uniqueness of all of us, right? That's not necessarily one size fits all. So, but we tried over all those years. We were looking especially at the kind of physical activity aspect, and today I want to give you sort of an overview of 3 areas that in this stage in the history, 2026, I would identify as a really, really promising areas where consumer health wearables transformed some aspects of healthcare-oriented tracking, monitoring, feedback that can lead to really significant transformation in healthcare, or is already having this impact. The first, atrial fibrillation detection. I know you were thinking that I would start from the physical activity probably, but no, that will be my highest ranked element here, silent heart rhythm disorder. I'll cover each of those 3 points in a minute. Physical activity tracking. So that's what I just said as an intro. So kind of what I've been also investigating in core. How can we take the same technology that puts us on sofa and use it to move us off the sofas to increase our activity, right? So in principle, it makes sense. So we also have some positive developments in this space over those many years. That's why I have to put this in here. And finally, infection detection. So early warning for viral bacterial illnesses. So I will now go through each of those areas to give you a really solid, to try to convince you to not hype things. I'm not here to hype wearable technology. Although, as I said, I'm passionate about digital technologies, AI. I do research in AI myself. However, I'm also a scientist, and we are in Royal Literary and Scientific Institute. So I want to give you a really solid, robust scientific perspective on this, where I use only absolutely top cutting-edge studies from around the world to give you an evidence for this. So first, just one small point here, and also I think regarding our earlier chat, Stuart, I'm not including here a continuous glucose monitoring devices. And the reason for this is that they're not exactly coming from the space of a consumer-oriented health wearables. There's been a long-standing research and technological development in glucose monitoring in attempt to address type 1, type 2 diabetes with better way of measuring it. Now, consumer wearable technology had a facilitating effect on some of the research and some of the innovation in this space, but I can't put it here because inherently it's not coming from this kind of consumer space. It's not original here. It has a much longer history than that. But this one is very interesting. Atrial fibrillation, a silent heart rhythm disorder. It's a kind of disorder that happens where an upper area of your heart starts spasming chaotically and randomly. It's frequently asymptomatic, so people don't know they have it. They just experience some symptoms of this arrhythmia. It affects over 1.4 million people in the UK, so 2 to 3% of population. And it rises sharply with age. 10% of over 75s have this particular condition. And finally, it increases stroke risk by fivefold, by 5 times. So it's quite serious. And this has been pretty much cracked with wearable technologies by 2 really, really large and impressive studies that have been done in collaboration with industrial companies in this case. The first one was Apple Heart Study, large-scale assessment of smartwatch to identify atrial fibrillation, done, I believe, with Stanford scientists. So both of those studies I'm showing you here were done in collaboration with Apple and Fitbit, the second study, but it's been led by large scientific and clinical teams. They recruited absolutely enormous sample here, over 400,000 in both cases. In Fitbit case, 450,000. So really massive, massive scale of those studies. In fact, really, that's one of the smaller or kind of very important advantages of wearable technology that's much more methodological, and I'm not going to talk about today, but this is the kind of potential that it unlocks, the fact that they were able to recruit that many people wearing Apple Watch. Because of course, the popularity of this technology and how it was deployed, they created a platform for this. And then people were reporting, they were sort of collecting the data from the watches, but also people were reporting either to the clinics to take their real clinical ECG, electrocardiogram measurement to sort of have a comparison to how Apple Watch was measuring it, or Fitbit. And the key result here, it caught 95 out of 100 people who actually had atrial fibrillation, so 95% sensitivity. It correctly identified 97 out of 100 people who don't have atrial fibrillation. So 2 really important aspects, sensitivity and specificity for those studies, were absolutely through the roof. And that's for both of those. That's I'm kind of reporting collectively. What's more, in case of the Fitbit study, they managed to detect 57% of those asymptomatic atrial fibrillation cases. So cases where people actually didn't know they had it, and through the study, they found out. So this is really quite powerful evidence that was done, of course, through much more sort of lab-based conditions, as they were making an observation of the data streamed from the watches that they had with the participant had, and then a kind of ground truth that was provided by their visiting clinic. And in some cases, I think in Fitbit side, they were even sending the electrocardiogram devices for like a rental to participants, so they had it for the period of trial. Real-world studies in a clinical context have performed a bit worse. So a basal study, as you would expect, right? Once you move to the clinical context, when you have people with different types of arrhythmia as well, not only atrial fibrillation, but other arrhythmia conditions, sensitivity in case of Apple Watch dropped to 85%, specificity to 75%. In case of Fitbit, unfortunately, that went quite a bit down. However, one other study showed that the sensitivity restored when the physician was engaging with this data. So that was a kind of interesting result that came out from this second UK multi-center study with quite, diverse group of patients with cardiovascular diseases. Again, the automated algorithm had missed 1 in 3 atrial fibrillation episodes, so not that great. But with physician review, when they look at the data, that went up to 95%. So this is still very good news, although the performance dropped. And we always see this, by the way. This is really quite standard almost across every study I see in the real world. When you have a lab test and you have some algorithms that you develop, and you try to measure accuracy, specificity, sensitivity, you're getting great results in the lab in a controlled environment or in a kind of observational, more restricted context. But once you move it to actually a real world, in real hospital with a real life patients, those metrics are crashing a bit. But this is still the case. I have to tell you that it holds quite well, considering that's been moved to the real world. And this is the only feature now in those watches that have been actually approved, not approved. It's been, there is a different type of American FDA approval that is not a full approval, but like a lighter type of approval. I think it's called 501A or something like this. Basically, Fitbit and Apple now got this approval. So technically, if this data ends up with GP, that sort of gives it some extra reliability boost in this sense. So that's what I would say in those last 10 years have been one of the kind of biggest little innovation that came from those wearable devices, that they can clearly be used for this continuous management of cardiovascular disease, quite serious one. We can, of course, see the potential that this will easily expand to this type of conditions and become more embedded because of this ability to continuously track the heart rate, which again, you can almost never do in a clinical context unless you have a patient in the hospital for a long time. This, of course, brings this capability. Now, second case, physical activity tracking. So as I said, sedentary behavior is, of course, linked with cardiovascular diseases, diabetes, premature death. UK adults average 5.6 hours per day sitting. That's, I think, pre-pandemic statistic, though. And traditional advice, move more, lacks objective feedback or accountability. So, as I said earlier, we thought, could wearable be this holy grail that finally cracks it and empowers people to move more? Well, the story here is not as optimistic as with my first case with atrial fibrillation. Let me show you why. So, the two studies show a really big promise. First, a Ferguson umbrella review that looked at a big number of studies, over 400 individual studies, 39 systematic reviews, over 164,000 participants that were collectively in those studies. So this is like a big systematic analysis of all the evidence that was published up to that point around use of wearables for improving physical activity. And they found some modest improvements. Activity increased overall by about 1,800 steps per day on the average. Hi, good evening. Walking increased by about 40 minutes per day. And they also observed a weight loss, modest weight loss of around 1 kilo over 5 months. That's published in Lancet Digital Health. The second study that Stuart even mentioned is, of course, the UK Biobank accelerometer sub-study. So that's the sub-study that used the UK Biobank data, quite amazing data sets available. 78,000 participants wore devices for 7 days. They've been a representative sample for the UK population. They had a median of 7-year follow-up for any outcomes and tried to use objective measurement where they could. So it wasn't based on self-reports. And they had this really interesting finding that when you reach 10,000 steps, you can see about 40% reduction in mortality risks and 54% reduction in cardiovascular disease risk when you look at this kind of population. So quite striking. Now, of course, companies jumped on it, and you won't see many of those kind of images in my slides because of the copywriting things. I have a lot of icons, that's why a little pictograms, but not that many pictures because I got into trouble in the past of putting a lot of wearables on my slides. You might remember, in London, there were a lot of those billboards. When you went into Tube a couple of years ago, Vitality, health insurance company, was giving away Apple Watches for a relatively small fee compared to their original price. with a kind of incentive that you have to meet particular weekly or monthly goals in your physical activity to, well, keep your premiums down, basically, right? And at the same time, they also ran the study on this because they had a lot of data. So they started running a kind of observational large-scale deployment. So looked at about over, again, 400,000 participants across UK, US, and South Africa. The initial publication was in 2018, and then there was 2033 follow-up. So the core of this was giving people Apple Watch with a loss-framed financial incentives and a multi-year tracking, right? So their questions were how much people's activity improved with Apple Watch and whether it then persists with other watches where it didn't persist so well. So that's where we start to see a bit of a cracks in the kind of more long-term physical activity aspect. So yeah, with first Apple Watch, there was a great increase, plus 40%. Now with second, there was only plus 13, a third plus 11. So the initial boost was generally about plus 34% overall. But again, it was clear that there was a sort of a diminishing return, that this trends were going down with time. And in fact, then there were quite a lot of studies that further confirmed this. Most people discontinue wearable tracker use within 3 to 6 months of starting. And then they gradually return to the baseline of their activity. So pre-watch wearing, unfortunately. The reasons for this are quite several that were discovered by some of those authors. Novelty wears off. External motivation, so the device doesn't become intrinsic motivation. No ongoing professional support or accountability, forgetting to charge, wear device, so kind of some technical issues, and goals become routine, boring. So kind of they standardize. So people already know what they run, what kind of scores they hit every day. So that means that there is a limit to this big increase in physical activity effects that we've seen in the earlier evidence. And that effect is mainly just compressed in the short term, that without the somehow incentivization and some longer intervention maintenance, most people are likely to drop out from this, from basically actively tracking themselves or actively engaging with these devices. So it's not to say that wearables don't work for physical activity, but there is this limit in terms of moving from kind of short-term use to more persistent long-term use and impact of this long-term use. We've been thinking a lot about this with my colleague, Professor David Ellis, also from Bath, and we even sort of started to come up with some comprehensive guidelines and frameworks of what could be done, much more higher level, to try to mitigate those problems. So in terms of issues like device design is often intrusive or disliked by participants, and high attrition rates continue to limit effectiveness. We thought about sort of first, designing devices should be driven by researchers and end users, as well as those working within health. So as we were meeting at that time with both technology people, patients, GPs, other researchers, we realized that you really need the whole cohorts, the whole group to build more effective solutions. Understanding the role of individual differences is likely to correlate and predict uptake, success, and attrition of future interventions. It's incredible how ignored individual differences are with the wearable world frequently. Although it's a very personalized device, frequently they're made as one size fits all, really. With maybe, okay, you have a band that maybe is small, medium, and large, and so on, but there isn't a kind of inherent interface or device customization that could be done fitting much more your individual requirements, challenge, or goals. So that's one of the aspects, I think, that we observed. Quantifying then behavioral interactions from wearable technology will help further understand user experience and attrition. So again, looking not only at the data that the users generate, but also at the metadata of using the wearable, which we mainly observe more indirectly or through the lab-based studies. But again, there is, of course, clear potential with current data landscape to also look at the broader context of use of the devices. And then, of course, this could be quite a useful information to somehow timely reinforce any behavior change intervention, which the device is part of. We also found that frequently interventions were theoretically uninformed and mechanisms of actions were unknown. That was due to sometimes, of course, proprietary technologies being or algorithms being developed by the companies. So very frequently we found that we couldn't quite match very different accelerometers with a clinical grade experiment in terms of the step counts. There was a lot of variance and we couldn't quite figure out why, because we didn't have access to the algorithm that was calculating those step counts or calories. I'll come back to calories. Ooh, this one is really, really a terrible one, but I'll come back to this in a second. So increased number of theoretically defined behavior change techniques within current interventions, prioritize incremental basic research that aims to unpick causal pathways, acknowledge and evaluate and publish failures. So again, kind of looking at the broader scope, we thought that there were some gaps in existing research and in practices that could be mitigated. But there were also some positive and interesting and really strange things happening sometimes, like Pokemon Go, for example. If you don't know, that was a game that was released at one point by Nintendo. It had about 500 million downloads between July and November 2016, and about 20-30 million active users, over 3.6 billion in lifetime revenue. Now, the Pokemon Go was what's called augmented reality game. So you had your smartphone, you were launching the game on your smartphone, and you were pointing, and then you had a camera in the game that you were pointing in the real world. And because the game had what's called a geolocation embedded, so it knew where you are, and it kind of was mapping virtual characters in the real world. So people were walking around the streets and areas and all around the world and kind of working with their phones, trying to capture and throw balls, virtual balls in those Pokemons, in those little creatures that were virtually appearing there when you were pointing, let's say, at the floor with your smartphones. But that means that people started moving quite a lot. In fact, by 25, their increasing average physical activity for users who play Pokemon Go was about 25% across men and women of all ages, weight status, and prior activity levels. And you can see this exactly on this chart when you have on the left side, before the line, a kind of a baseline, a control user group level of activity, and the Pokemon group user that was even below this control group of the users, then poof, shooting above for about a month. But unfortunately, then the short-term effect finishes, and we can see a gradual drop. Unfortunately, then it drops further and comes back to the original level. But we really love this study, and we love this kind of accidental phenomenon that a kind of a gamification, a gaming activity became a physical activity. And I think that there are some hints to it where we have to go with the kind of long-term approach with using wearables for physical activity. And some apps, some fitness apps are gradually trying to tap into the kind of these principles of gamification and giving users some more virtual, abstract goals rather than just this clear goal of hitting the step count or a calorie count. All right, so that's the physical activity part. Let's move to the third aspect. In fact, infection detection. So early warning for viral, bacterial illnesses. What's the rationale behind this? Well, with wearable technology, you can quite easily detect various physiological signals, elevated resting heart rate or disrupted heart rate variability, changes in sleep patterns, temperature fluctuation, reduced physical activity. And now a lot of those factors also very strongly correlate, of course, with infections. So especially when COVID hit our global society, a big number of research projects started around how we can use wearable technology to detect COVID and other influenza infections. How can you even track or trace the symptoms before the actual onset, if it's possible, with what margin, how accurate it is if you do this on the population level. So there were quite a few, really, there were a lot of studies coming on this. I mean, as with any domain, COVID was a quite special time where science suddenly, everyone was COVID expert and everyone was in scientific world publishing a COVID-oriented paper. So this was quite similar. There was a lot of really bad studies published in this time, but some decent one as well. There were especially those 3 studies, the TECT, Stanford, TempPredict, that showed a really high level of accuracy detection with either wearable and some initial symptoms presence. In case of Stanford, I think it was just the wearable device. And in TempPredict, they even were able to detect it sort of 2.75 days early. I think the Stanford detect also had some slightly early onset detection before the participant actually felt the symptoms. So preliminarily, this looked really promising. At the same time, we had a lot of some studies around kind of more broader infections, cold, different other types of influenza, particularly Fitbit population study and Duke severity prediction. Those 2 studies look at quite sort of in a quite robust manner, again, large population. So the Fitbit population study looked much more at the kind of aggregated level. So they weren't looking specifically about individuals, but more taking samples from a lot of Fitbits and trying to figure out. And I think that they were contacting samples of those patients as well. They found generally a strong correlation with official influenza-like illness rates. So they showcase some population level surveillance capability. So CDC is this organization in the US that tracks diseases. For H1N1 flu, they also had similar level of accuracy for detection, also 12 hours before symptoms. And for common cold, there was even higher accuracy, about 92%. So quite promising study, quite high level of accuracy, also matching in some case the CDC, so kind of official surveillance, health surveillance data. However, again, that's one of the areas where we have to say, but there were some issues. So the first issue was around false positive from non-infectious triggers. So when other group of researchers started looking at a lot of others, they found that only 11% were actually infections and 48% from those alerts were self-contextualized false positive. So that was a case where people were just over-interpreting things and the data themselves as being ill, are having symptoms. So kind of self-assigning this. And again, in this false positive, the common triggers could be intensive exercise, very common was stress, poor sleep, alcohol and caffeine intake, menstrual cycles and pregnancy, medication changes, chronic conditions. So quite a lot of things were affecting this false positives. And then a group of researchers looked comprehensively at those studies that I showed in previous slide, published, by the way, in quite impactful, high-impact journals, scientific reports, Nature Medicine, Nature Biomedical Engineering. And they published a really damning report in Lancet Digital Health, showing that majority of those studies showed signs of data leakage, so that they mixed training with test data, meaning that they sort of over-provided almost the information for the machine learning model to make the prediction. They gave too much information because they gave an information they shouldn't, that they should keep on the side for testing. Cropped evaluation windows, so the studies were cherry-picking periods showing best performance, so they were just focusing on some time periods. Publication bias, that studies exclude participants who always test negative. And overfitted models. So again, it worked in control studies, but majority of this didn't replicate at all in the actual real world deployment outside the clinical studies, but in practice. So that performance, they concluded the performance was greatly inflated in most of the studies. What's more, it was very unspecific. So of course, in any of this detection, they couldn't actually say what type of influenza you have. Or I think there were some cases of bacterial infection as well. And again, it was quite unspecific. So for that aspect, I would say that the evidence definitely shows that we can find some traces that somebody is getting ill, but it's very unspecific. And it works much better when you're just looking at the broader population and the kind of larger population. So you allow yourself some error margin at that case. And then the data matches more to what we see from kind of official sources. So that's sort of in more general kind of population level health surveillance. This is probably quite useful capability that will be developed further. Now, so those are the three areas that I wanted to mention, but the story, of course, doesn't finish here. I have to now mention to you some other significant issues that are still plaguing health wearable world right now and hasn't been quite resolved entirely to this point. First, and really serious one, is validation gap. Only 11% of consumer wearables have been validated for any health metrics. That's unfortunately what you might say a dirty secret of wearable industry. So in this study called Living Umbrella Review, again, looked at 24 systematic reviews, 249 validated studies, over 430,000 participants, and 310 devices tracked. They found that only 11% of those 310 devices were validated for even one metric. Only 3.5% of needed validations were actually conducted, and only 70%, 1% of validation studies used a gold standard reference as well. That wasn't actually such a bad statistics. At least 71%, if they use something for gold validation, they used gold standard. Only 40% followed best practice statistical analysis. So there is a really serious validation gap here. The wearables that are coming on the market are, of course, not regulated by any means. So in many cases, we as a consumers can't quite differentiate whether the device is actually being somehow validated for accuracy, for reliability, or whether it's just a hype. And I'll show you examples where it's unfortunately a hype and even a kind of dangerous hype. And one of those is calories inaccuracy. This is one of the, I would say, the most terrible ones. Wearables have error rates between 27, that's the lowest, that's the minimal error, to 92% in tracking energy expenditure. It's really, really terrible. The study it was a kind of relatively small study in Journal of Personalized Medicine. It looked at 7 popular devices. They tested in the lab with 60 participants. The best performing one was Fitbit Search, which had about 27%. The worst was Pulse On, which had 92% median error. None of this device actually that's on the market right now achieved anywhere close to acceptable accuracy. Apple Watch, the one that is the most popular in generally the Western societies, had been around 40% median error. Samsung Gear, again, very popular, very close to that 39.7. So yet millions of people base their diet and exercise decision on these numbers. when they track their calories. So there is a really, really serious one that's not talked enough about. It's a really another kind of little secret. Sleep inaccuracy. That's another one that we, of course, love, sleep tracking. There are various ways of doing this. We can have a smartwatch that tracks our sleep during the night, a ring, or even we can put our smartphone in the corner of the bed, run a special app that has an algorithm for sleep pattern detection. And the idea here is that because of the movement sensitive accelerometer, you will get this differences between rapid and non-rapid eye movement changes in the sleep pattern. So you will know when people move less and more, and you'll detect the phases shifts. However, consumer wearables overestimate sleep by about 40 minutes and misclassify sleep stages more often than they get them right. So another study in JMAR, 11 devices tested with 75 participants. They used gold standard for reference hill, so polysomnography, PSG. That's a kind of a clinically established device to measure sleep patterns. And they found, plus 40 minutes total sleep overestimation, 12 to 39 minutes overestimated wake time, sleep stage classification between 26 to 69 when F1 scores, when 1 is perfect, 0 is totally random. And the worst accuracy was on actually disrupted nights. So when it's actually probably matters the most, right? To provide when the clinical measurement would matter in this case. So if you are using any wearables technology to diagnose sleep problems, you're working with fundamentally flawed system as well as with the calories. Finally, skin tone bias. So heart rate errors on darker skin are nearly 3 times larger than on light skin. Now, there is a technical reason for this that we know for a very long time. In pulse oximetry, so, when we take, it's not flashing right now, but there is an oximeter there under each of our watches that emits green light. This green light penetrates our skin, but gets absorbed by the veins. So this can be used to detect heart rate. However, the problem is that melanin in our skin also absorbs green light. So the more melanin you have, the more of the green, and the more melanin is associated, of course, with darkened skin tones, the more of the green light your skin will absorb. Which means that in the light skin, the beats per minute error is around 4 beats per minute, but for medium or dark skin, it's about 11.7 to 11 or 8 beats per minute. And in fact, this study already cited this particular quote. American Heart Association says devices should be within 10 beats per minute of true heart rate for safe exercise guidance, and 11.7 beats per minute error, it is exceeding clinical safety margins. And another meta-analysis, systematic review, found that 40% of studies with wearables that were using this kind of technique showed significant accuracy reduction in darker skin tones. Again, this probably will be resolved quite easily because it's a more technological problem. We can emit different lights like infrared, which doesn't have this issue. So I would say that this is probably on the way to be quite resolved. Now, how I'm standing for time. Oh, wow. It's already there. Okay. So I promise that I will also mention in this talk the new frontier. As you also mentioned, the new kid on the block, generative artificial intelligence that, as you correctly said, we hear about all the time. So just to briefly recap what we mean by this. So generative AI refers to a range of artificial intelligence technologies capable of generating new content across various media, including text, images, video, and sound, by learning from existing data patterns. This capability relies on highly advanced machine learning models usually deep neural networks. And training those models requires very, very large data sets. That by very large data, I mean the entire internet, that includes the entire human history of writing in terms of literature and everything that was ever published, basically in a textual form or then as a publicly available imagery. Specialized algorithms, yes, this aspect has been a result of probably 40 years of work and evolution in sort of mathematics and statistics of AI. And enormous computational power. Yes, that's a final component. We have reached now the point in history computationally when actually we can run this deep neural network at scale in parallel. We couldn't do that before. So before, this wasn't even technically possible. But this is still a very, very tricky process. So only few companies in the world can actually train their own what's called foundation model from scratch. Currently, those companies are pretty much OpenAI, Microsoft, Google, and Meta. All the rest are pretty much building on others' existing model and what's they fine-tuning or retraining, which is a different, less intensive process already. Anthropic probably will be there as well amongst those top ones. But let's make this absolutely clear. The generative AI capacity for self-guided learning and the replication of complex data structure with minimal human intervention represents a significant breakthrough in the evolution of artificial intelligence. I mean, when OpenAI released ChatGPT, I probably didn't go to sleep for 3 or 4 days the first time because I was just so hooked on it. So clearly, this will somehow also disrupt and influence the wearable market. In what way? Well, when we think about generative AI, of course, we are in the early stages. So some of the stuff that I will be showing you about generative AI is more hypothetical or work in progress. Some is existing, but it's mostly not at the stage where it's sort of ready for any serious deployment, but it's really promising. So the key promise here is, of course, this intelligence layer of being able to, that your watch doesn't just show you heart rate, but it shows it to you more contextually. So this first aspect would be something like natural language health insights, right? Very logical, that AI translate raw data into plain language explanation. Instead of seeing data, will see here something like your heart rate variability has been 15% below baseline for 3 weeks, correlating with reduced deep sleep. This suggests chronic stress, right? For example, so this is really promising domain with AI because generative AI is also right now multimodal. So it can effectively combine different source modalities, image, video, text, audio, and combine them all into a single output, in a single comprehension by processing this multimodal data. This capability wasn't there to such a scale and such a depth before. So that's quite promising for this aspect. There are already projects ongoing like GPT Health, ChatGPT Health, or Google Met Palm 2 and with Fitbit integration. The critical risk is still, of course, hallucinations. Those generative AI systems hallucinate, they make up things, but in a very authoritarian, confident tone. So sometimes it's tricky to spot it if they do it, but they do. They make a lot of mistakes still. And mistakes, of course, are unacceptable in a clinical context. Well, they are acceptable with much smaller error rate than it is for this issue. Mental health, digital phenotyping. I wasn't talking much about sort of wearable and mental health context because up to this point, it's really been quite not great, to be honest. There hasn't been that much of a really solid evidence of some sort of capability to track or detect, let's say, the traces of depression or anxiety from passive digital traces. Now, there's been a separate study in keystroke dynamics, so like typing speed errors or hesitation, voice prosody, flattened pitch, movement patterns, reduced life space, phone usage, intensity. So looking at kind of this sort of traces and how they correlate with symptoms of depression, anxiety. Of course, it's quite envisioned possible that AI could again take this aspect to the next level by sort of bridging some technical issues here, and basically addressing the complexity of the mental health, for which kind of a complex AI system could be good to consider many different factors that come into picture in the consideration. But of course, the critical risk here is passive surveillance without consent. When we start considering such a low-level metadata, like the examples I'm giving here. Finally, synthetic data for privacy. AI can generate realistic wearable data, train algorithms without exposing real patients' records. That's been a big issue with generally implementation of and testing of these technologies. Of course, healthcare providers are always very sensitive about patients' data, who's accessing it, how it's managed. NHS is very risk averse in this sense. And this limits sometimes the research that we can do on population. With synthetic data, we could potentially generate synthetic personas that are based on the real world data, but they are not revealing your personal heart rate profile or activity profile, but is capturing it statistically in a similar way. So that is a big potential for really a new frontier in clinical studies that will be done in almost a virtual landscape. Is already first steps in this direction, but it may, of course, not capture the real world complexity that we see. And there are edge cases, sensor noise, and can amplify existing biases if trained on biased real data. Yes, that's been kind of a big issue with machine learning training. So this, of course, also a problem when it comes to implementing any Gen AI alongside any sort of wearable technology data. Now, even more problematic is, of course, the fact that technology moves at exponential speed here, but regulations at the bureaucratic speed. So we already have some things mostly unregulated are deployed. Apple Watch has some proprietary AI for insights, undisclosed algorithm. Fitbit and Google have their AI-powered health recommendation, unknown training data. Oura Ring come up with like a physio-psychological resilience score, but the methodology is unclear. There are tons of consumer mental health apps that do some sort of passive monitoring, AI scoring, of course, not based on much of research or not really regulated anyway. So we don't know quite a lot in this context. We don't know which AI models are being used, what data trains the algorithms, how insights are generated, who has access to the derived scores, whether data is sold to third parties, how to opt out meaningfully. A lot of problems that are not only characteristics to this context of wearables with AI, but are, I guess, characteristic to general deployment of generative AI right now in different systems and around the world. I think being aware of time, I'm going to just quickly skip through the regulatory part that I just wanted to tell you that just the conclusion from this regulation is that none of the existing roadmaps or regulation even consider wearables as a meaningful technology. So MHRA, AI, and machine learning roadmap in the UK focus on continuous learning algorithms. You have to demonstrate performance across demographic groups, but consumer wearables are not covered. NHS AI labs, again, they focus nicely on imaging, diagnostics, hospital workflows, which are great areas to focus for the AI to implement, but nothing there on consumer wearables and AI integration. And same actually with international comparisons. If you look at EU AI Act, that's kind of for high-risk systems that require transparency. But consumer wearables are classified as minimal risk. And same with the US Federal Drug Agency. There is a guidance on AI and ML in medical devices, but consumer wearables often exempt, classified as low risk. So regulations are ignoring wearables, consumer wearables, in short. It's a gray area. It's really fascinating because you have this situation that there is a wearable like this that already has some FDA approval to particular technology, but overall is still just a gray area, unregulated consumer device. So we have a lot of those critical gaps then that are related to the governance of those technologies. No requirement to disclose AI methodology to consumer devices, no mandate for demographic fairness testing, no regulation of mental health scoring algorithm, no limits on data monetization, and no meaningful consent mechanism, take it or leave it, in short. So yeah, I guess I'm finishing on slightly concerning bit, but I'm hoping that we do get into it and resolve this, especially from this kind of generative AI angles. But just to quickly sum up of what I tried to convince you or tell you today, 3 things that seem to roughly work is with wearable health in the consumer space is atrial fibrillation detection in high-risk population, especially when validated with a physician review, physical activity promotion for short-term interventions, infection detection, but again, for surveillance, large-scale population level epidemiological studies, not diagnosis, but only when deployed strategically for specific conditions, validated rigorously against gold standards, distributed equitably so we don't leave people behind. And it should be governed properly, which, as I mentioned, especially with Gen AI, we need transparency mandates, demographic fairness testing, mental health protections, so explicit consent, not selling data, hallucination safeguards, and in the current state of the world, probably data sovereignty as well, as we want to have this certainty and safety for how our data will be managed and transferred between the system. So that's what I wanted to tell you about today. Thank you very much for coming.